All right, why don't you just go ahead and get started so we're not waiting all afternoon for 'em.
Sure, sure. All right. Thank you all for signing on a Wednesday. We'll be talking about two topics today. So one is sports biomechanics, and the other one is principles of MSK rehab. And so we'll start with the biomechanics. All right, so this section is going to be broken up into different things: throwing, gait analysis, cycling, things like that. So just starting with throwing, there's a lot of questions. A lot of this stuff shows up on our board exams, and a lot of it is just memorization, plain old. And so hopefully, with some pictures and just reviewing this, not in a paragraph format in a textbook, hopefully we can call out a couple details that we can try to remember about each of these things. So getting started with the kinetic chain of throwing, we know that pitch velocity comes from 50% from the trunk and the lower extremity, and the other 50% from the shoulder down. Yesterday, with Dr. Goldberg, we just had a patient, and they were doing everything for their upper extremity, but nothing for their core or their lowers. And so I think it's just super important to keep that in mind. And we're going to go through the different phases of throwing and see why and where the legs and the trunk come into play. When we talk about stride length, about 85 to 100% of the height, the length of that is that much of the pitcher's height. So they're taking a pretty big step forward. And I guess we'll try to make, not every slide has questions, but this is just so that we kind of all stay tuned in. But true or false, what do you think? Increased stride length improves velocity.
I'm gonna say false.
All right. It's actually true. But I see where you're going. So if you overstride, that can certainly decrease your velocity. So I think, just important to, a lot of these questions, I feel like on the boards, it's, which of the following is false, and then they'll have a bunch of sentences like this. But I think, it's just good to know that in general, increasing the stride length will improve velocity. So going through the different phases, the first phase is the wind-up phase, and I can never remember like when each phase starts and stops. So we'll try to just remember, kind of simplify it so that we remember it. So the wind-up, it starts with the ball in the glove, and the wind-up phase will end when you remove the ball from the glove. At this point, your body is rotating away from the home plate, and this is different because your body, in the later phases, will turn towards the home plate. So just trying to imagine what kind of questions they could ask, and so just be careful of whether the body is rotating away or towards home plate. The stride leg will elevate and flex at the hip and knee, as we see there. You will hit a balance point in the wind-up phase, and that's where your center of gravity is stable, and then you're ready to propel the ball forward. At this time, your shoulder musculature is very minimal. Most it's lower extremity. So really, this force that you're generating on the ball is starting in your legs, starting from the ground and going up. And that's why, again, the leg and the trunk are so important. The second phase is the early cocking phase. And so this will start when you take the ball out of the glove, and then your stride leg is going to start stepping forward. Your hips rotate forward and open, and then it ends when your foot contacts the ground. So if you can see, hopefully you can see my cursor here, but really when this leg hits the ground, that's when the early cocking phase finishes. At this time, you're using a lot of your scapular stabilizers, your traps, your serratus anterior, deltoid supraspinatus, but then even your static stabilizers, your inferior glenohumeral ligament. Hip internal restriction or external restriction in the stride leg. So, one hip is internally rotating, this is internally rotated, this one is externally rotated. So any restrictions in internal external rotation of the hip is going to cause issues in this phase. So that's something to remember. Also, we should note that the hips are rotating forward in this phase, but the torso has not yet. And that's going to be important because in the late cocking phase is when the trunk is rotating forward toward the home plate. So really, we want to first open up our hips and then rotate our torso. And that's going to be important because if you switch those up, that can lead to injury. And we'll talk about that later and injuries that can occur. But really, late cocking phase ends when shoulder reaches maximum external rotation. So really, it's at this stance right here. True or false, the amount of external rotation correlates with the speed of the pitched ball. What do we think?
True.
Yes, that's true. Exactly. And again, with maximal external rotation, we can imagine the amount of forces on the shoulder and on the elbow. So a lot of your scapular stabilizers are going to be very, they're going to be working a lot more. But even weak knee extensors of the stride leg can impair the force generation. So again, having strong quads is going to be just as important. Now, late cocking phase, this phase is where you will see the late cocking and the acceleration phase. It's these two phases where you're going to see most of the injuries occur just because it's the highest stress on the arm and the shoulder. So what are some things that can happen? One is anterior instability, and that is really just repetitive microtrauma from you're stretching the ligaments and you're doing an eccentric contraction of the musculature. And as we know, the eccentric contraction generates the highest force on those structures. And so repetitively doing that can start to cause some instability. Well, we can certainly see impingement because of the rotator cuff and even the labrum. We can see GERD, not what Suze and Austin have after drinking coffee, but this is GIRD. And remember, we define that as when internal rotation is lost and external rotation is gained, but your arc of motion should be 180 degrees. When it becomes less than 180 degrees, that's when you have the internal rotation deficit. It's when the IR lost does not result, is greater than the external rotation that's gained. And so, but if their external rotation is gained, let's say 40 degrees, and you lose 40 degrees of internal, that is not considered GERD because you still have an 180 degree arc of motion. You just have a more externally rotated arm, which is very common in pitchers. Biceps tendinopathy is also going to be big here just because the long head over the lesser tuberosity. And as we know, the biceps connects to that superior labrum, and we can see labral tears because of that as well. In younger kids, we see little leaguer's elbow, and really that's a umbrella diagnosis for traction apophysitis. It could be a stress fracture of that medial epicondyle. And then in older people, we can see the medial epicondylitis. And then, of course, on the medial side of the elbow, you also have your UCL. And that really can happen due to a few reasons. One is a dropped elbow, and that's really because your scapular stabilizers are fatigued, or it could be your sidearm. You're doing sidearm pitching because your trunk is not rotating as well. And then the third is early trunk rotation. So again, you want to step down and then rotate your trunk. If you rotate your trunk too early, you're not generating that force from the lower extremity. You're doing more upper arm, shoulder, and elbow. And that's why that trunk rotation is so important. Then we get to the acceleration phase. Again, remember, late cocking and acceleration phase is where most of these injuries are happening. And why is the acceleration phase so deadly? Remember, it begins at maximal external rotation because that was the late cocking phase, and it's going to be propelling the ball forward. It's accelerating the ball. The peak angular velocity of the shoulder, your shoulder is internally rotating up to 9,000 degrees a second. That's insane. And so with the help of ChatGPT, I was like 9,000 degrees a second. If like you take a standard car tire and you rotate that 9,000 degrees a second, how fast would that be? That's like a car traveling 105 miles an hour. And that's insanely fast for the human body to do with the shoulder. So it's just a remarkable thing that, one, we can even produce these kinds of forces over the shoulder, but you can imagine how much stress over these structures is actually happening. And so the acceleration phase is ending with ball release. And that's why at the end of this, it's the balls leaving the hand there. Your subacromial impingement is going to be very common because they're internally rotating, adducting the arm, and then you're going to get all these medial tension injuries like we already talked about. And really, when we look at the forces that are on the medial elbow, it's about 64 newtons per meter. Forgot the exact what that is, but essentially, what does that mean? 64 newtons is like a very small car engine or an electric drill or a bicycle crankset, or a motorcycle engine or a household appliance motor. I mean, it's a lot of force that we are putting on the medial elbow for this. So that's why, again, thanks ChatGPT for giving me examples of what 64 newtons is. Then we get to the deceleration phase. So the deceleration phase, again, remember, begins after the ball release because that's where acceleration ends, and then ends when your arm reaches 0 degrees of internal rotation. And so when you're in this phase, you're internally rotating, but you're decelerating. And so that's when you're going to get a lot of posterior instability because the posterior structures are resisting glenohumeral distraction because your shoulder wants you're about to go through your follow through, so it's going away from your body, and so all your structures in your shoulder are trying to keep everything held back. You can see rotator cuff tears. Again, you're getting an eccentric contraction of these structures. Slap lesions, again, Bennett lesions, which is that ossification of the posterior inferior capsule. And then the biggest one is valgus extension overload. This accounts for 65% of surgeries for medial elbow pain in professional baseball players. And this happens because there's impingement of the olecranon against the olecranon fossa. And so when you have constant impingement of those structures, you can get osteophytes, loose bodies, scarring, and of course, a lot of pain. So, and then finally, follow through phase. And this is really a passive phase. There's not much potential for injury here, but really this is just your body catching up due to the rotational centripetal force. And if an injury occurs, it's really, again, that posterior arm and trunk because your body is, again, trying to dissipate that energy and hold your shoulder back and keep it in its socket. So these are all the phases, again, from wind up to early cocking, late cocking, acceleration. 80% is just in the wind up to late cocking. So this is while the ball is still in your hand. The acceleration phase is only 2% of the time of a pitch. And when we're internally rotating that quickly, producing that much torque, that much force, you see that the acceleration phase is requiring the upper extremity. 80% of this, of the time of a pitch, is all going to be trunk and lower extremity. So again, just to stress that importance. So when we keep throwing, we've already talked about this, but for the shoulder, we'll see increased external range of motion. If we don't see the internal rotation, if the internal rotation deficit is greater, we're going to have GERD, and that's going to put you at risk for impingement. There's a strength ratio of internal to external rotation of 3-2. I mean, even when we strength test, we know the internal rotators are generally stronger than the external rotators, but it's a ratio of 3-2. And if you have an imbalance of that, you're going to be more prone to impingement. In the elbow, we already talked about the medial elbow and how much force goes on there. So those are some of the changes that we see. I have seen a question about pitch counts and just the maximum number of innings per year based off of age. I mean, this is a table that, I don't know how many times I'm going to look at and not memorize it, but essentially, when we look at just max pitches per game, around 7 to 8, it's 50. By the time you get to 100, you got to be about 16, 17. So that's about double or just over double. So just keeping some of these numbers in mind. Max innings per year, when you start 7 or 8 is 60. Getting up to 100, you have to be at least 13, 14. So again, just things to keep in mind and try to memorize these because they love to ask these questions. Some more true or false. Curveballs and sliders should not be pitched until puberty has been reached. What do we think?
So I would say a traditional curve, but most people don't throw a traditional curve anymore. The old school curve, people would really like snap and go circumferentially around the ball. Now people just go kind of down the seams and it's safe to throw. So, but that the old school teaching was no off speed pitches until you were old enough to shave, but I don't think that's the case anymore.
Yeah, exactly. Yep. And so I don't know how, I think the boards will still kind of be more cut and clear with the questions. And so, but you're absolutely right. That is true. And then what about youth pitchers should not compete in baseball more than 8 months per year, and then no overhead sports during those 4 off months?
I don't really have any data to back this up, but my gut says that's true.
Yeah. Yep. And this is just, again, to prevent those overuse things, give your shoulder and elbow enough time to to rest and heal. And then true or false, no pitcher should appear in a game as a pitcher for 4 consecutive days, regardless of pitch count.
I feel like that should be true.
Yeah, and again, this was just mean of me to put this one on there. This is false just because it's 3 consecutive days. It's tough to memorize some of these numbers, but I feel like these are the things that I feel like we might get asked. And so no more than 3 consecutive days, regardless of pitch count. We talked about hanging or dropped elbow. Again, this is a sign of fatigue, and that will increase your injury to your rotator cuff and your UCL. And again, opening up too soon is also, remember, rotating shoulders prior to the stride foot striking the ground. So you want to strike the ground, then rotate the shoulders. All right, enough of pitching. Moving on to swimming. There are 4 stroke phases. This is just for freestyle. We have the entry and the catch phase. We're looking at this top arm here, where it goes from hand entry into the water to the beginning of the backwards movement. The pull phase is when you're pulling. The pull phase stops when you're hit 90 degrees. It was actually kind of cool. I mean, you never think that the first part of that stroke is pulling, the second part is pushing, even though it's all one smooth motion. But that's the pull versus the push. It's this 90-degree mark that differentiates it. And then the recovery is, your hand releasing out of the water until going back into the water for the next stroke. So that's the recovery phase. You have different types of drag. This is pretty, makes sense just from the names of it. Form drag is your body's form. You want to be as horizontal as possible to the water, because the less drag there will be. The more vertical you are, the more drag. There's also wave drag. That's turbulence at the water surface, either created by the swimmer from the bottom of the pool or from the sides, the water hitting the side of the pool and coming back at you. And then there's frictional drag. Skin and hair and body suits can cause frictional drag. So just some terminology. When we look at kick patterns, knees should only flex 30 to 40 degrees in the flutter kick. Hip flexion should be minimal. There's different types of kicks, the 2-beat flutter kick versus the 6-beat flutter kick. They didn't really Finoff book didn't go into detail about the differences in between these, but they just said as these are 2 types of kick patterns. There is a whip kick in breaststroke, and that creates a valgus stress at the knee. So you can see a lot of medial knee issues as MCL sprains or pes anserine, tendinopathy. Common stroke flaws. One is body position. We talked about not being horizontal, so we want to stay as flat as possible. Hand entry is adducted, meaning your hand is entering past midline, and that can make impingement worse because you're going into a more internal rotation. Poor body roll. You ideally want your body roll to be 45 degrees as it gives power. But if you don't have as much body roll, you're again using more of your extremities, so it's going to make the impingement worse. And then having a straight arm during recovery, this makes impingement worse as well. You want to teach a high elbow on recovery. And so they use a combined elevation test where you put your hands together, keep your forehead touching the table, and then you lift your arms up in the air. And this really trains your arms to extend backwards, use your scapular stabilizers, and have a high elbow when your elbow is bent. And then too much length. So a long stroke improves propulsion, but again, that's going to stretch out your rotator cuff more. So any of these modifying factors can increase your risk for injury. So general rehab principles for this, really want to keep the scapula strong, keep the rotator cuff strong. The serratus anterior is actually functioning at its 75% of its maximum testability. So it's commonly overused. So making sure your serratus anterior is, you're working that out and keeping that strong. We are all familiar with the sleeper stretch to prevent GERD and stretch out the pec with pec stretches. And then cervical and thoracic mobilization, just so you can have good head rotation and trunk rotation. All right, and so that was swimming, nice and short. Moving on to gait. Walking, we'll talk about walking gait and running gait. So in the walking gait, you have your stance phase where your foot is contacting the ground from heel strike all the way to your toes lifting off the ground. And that's called the stance phase. That's 60% of the time. 40%, that leg is out of the air or off of the ground in the air in the swing phase. So 60-40. And we'll see that in running, that will change. So when we look at the running gait pattern, we see that the stance phase now is much less. It's only 35%, while the swing phase, where the leg is up in the air, is 65%. So the percentage of the gait cycle spent in the stance phase is inversely related to speed. The faster you go, the less time your leg is touching the ground, which makes sense. In the stance phase, the lateral foot contacts the ground first, and really energy absorption is the key. And the body is lowering its center of gravity in the stance phase through hip flexion, knee flexion, and ankle dorsiflexion. So it's all in the sagittal plane of motion. And we know that limited ankle dorsiflexion can cause a lot of ankle issues as well. Foot strike, there's this whole thing of rear foot strike versus front foot strike. And even in elite runners, most people are actually rear foot strike. Front foot strike does decrease the rate of loading. It does decrease joint torques, and so decreases your risk of stress injury and stress fractures. And so if that's a question, definitely front foot strike is something that you can try to switch to prevent that as a gait in a gait analysis. When we talk about barefoot runners and minimalists like running versus shoe wear, barefoot running actually promotes forefoot strike, while shoes are more rear foot strike. And so that's why you also may see decreased injuries in terms of impact injuries from barefoot running. And then we have pronation versus supination. Again, possible things that we could get tested on. Pronation involves ankle dorsiflexion. If you just try to pronate your foot right now, you notice that you're dorsiflexing your subtalar eversion, and then your forefoot abduction, it's going out. And if you supinate your foot, you see that your ankle ends up plantar flexing, inversion, and forefoot adduction. So these are, again, just fancy terms, but I feel like just doing it on yourself and kind of understanding, yes, that makes sense, so that if it shows up on an exam, it isn't too confusing. The first half of the stance phase is pronation. The second half is supination. And so in pronation, you're going to have eccentric contractions, while supination, you're going to have concentric. So again, you're using both, all types of, anterior, posterior muscle groups, concentric and eccentric contractions. True or false? There's one specific running style that's ideal for all runners. And, this is false, because anytime you say all in medicine, it's likely false, right? So there's no one running style that's ideal for all runners. Everybody's different. There's no one shoe that's perfect for everyone, right? Everyone's different. They have noted different biomechanical variables to possibly decrease injury, but all of them have unclear clinical significance. And the definitions of normal have not been established of like what normal biomechanics are. They know we see things, but not changing them doesn't necessarily mean we're going to decrease risk. But generally, what do we see? We want to stabilize the core, keep the abductors strong, make sure we have good hip flexibility, and then ankle and foot strengthening and flexibility. So again, those sagittal plane movements, knee flexion, ankle dorsiflexion, to better dissipate the ground reaction force. And jumping. So when we talk about jumping sports, such as basketball, we're obviously thinking about ACL injury. And so what are some mechanisms that cause it? You have an increased risk if your knee is in a valgus position. We know that's a very compromising position due to stress on the ligaments. Your quadriceps dominance, so having a good quadriceps to hamstring activation ratio, making sure the balance between those muscle groups is good. Trunk dominance, deficits in trunk control can definitely affect distally, so keeping your core strong. And then leg dominance, having either asymmetric body weight distribution, maybe they're having pain on one side, so they're shifting their weight onto the other side. And one way to dissipate this is, again, increased knee and hip flexion, ankle dorsiflexion, all that sagittal motion stuff. The more you bend your knees and dorsiflex your ankles when you come down from a jump, the less risk you're going to injure your ACL. And then finally, cycling. Cycling, they talk about bike fit, so where your seat should be, where your handles of bars should be, all that kind of stuff. So just some more definitions of saddle height. Really, when the pedal is at the bottom of the downstroke of the bike, your knee should only flex 20 to 30 degrees. If it's more or less than that, that's not ideal saddle height. And we'll talk about some of the injuries that can happen with that. Saddle tilt, it should be pretty much parallel to the ground, but if you slightly anteriorly tilt the saddle, that could reduce some low back pain. The drop between the saddle and the handlebars, usually 3 to 5 centimeters. It can be anywhere between 0 to 8 centimeters as well. But as we know, the larger the drop, the more aerodynamic. But you have to make sure that the person's core and hips are strong enough to stabilize when it's more aerodynamic. Because if you have a very aerodynamic posture and your core and your hips are weak, that's going to put a lot of stress on those areas, and that's going to cause pain. And then wrists held in neutral position is what we want. We don't want them wrist extended or flexed. And so what can happen if you have prolonged weight bearing when your wrists are held in neutral? Anyone have an idea of problems that can happen?
Ulnar neuropathy.
There you go. Guyon's canal. That's when it comes up. Exactly. And then if we want to do a dynamic study of bike fit, there's obviously video analysis, just like gait. People can measure wattage. If power output improves, then whatever change you made to the saddle height or saddle tilt or the height of the handlebars, that's probably going to work. And then they even use heart rate to measure performance after they change one of those variables. So what common injuries that can happen in biking? Knee. So this is actually cool way to think about it. Upper limbs are more susceptible in traumatic injuries, which makes sense. And then lower body is more susceptible to overuse injuries. So I feel like it makes sense when you hear it, but just hearing it like that, I was like, okay, that it's a good way to kind of memorize that into our brains. So if the seat is too high or too far back, we have a lot of stress on the posterior structures. Because think about it, if the seat is too high, then you're extending your knee quite far at the bottom of the downstroke. And so it's going to lengthen your hamstrings, your gastroc, and that's going to put a lot of stress on them. But if the seat is too low or too far forward, you're going to bend your knees a lot, and that's going to cause a lot of that anterior patellofemoral pain. You can get medial knee pain with toes pointing out, or lateral knee pain with toes pointing in. Injuries to the ankle, Achilles tendinopathy. This can happen if your saddle height is either too high or too low. Because if it's too high, you're excessively stretching it like we talked about. But if it's too low, you're going to push your heel down excessively and put a lot more force through that Achilles tendon. And one way to prevent this is the heel should not drop below horizontal on the downstroke. So I think even for all of our Peloton users, it's important that the heel doesn't drop below when we're trying to generate that force. And then we can also get metatarsalgia or interdigital neuralgia. That's when you don't have heel contact on the pedal and you're mainly using your mid and forefoot. That puts a lot of stress on that area. And it could also be because of tight fitting shoes, stiff-soled shoes, or just long rides. And so changing the shoe size, the shoe shape, putting orthotics, all of those things can help that anterior foot pain. And then spine. You can have cervicothoracic pain from just extending your cervical area. And to prevent that, you can decrease the reach or raise the handlebars just so you're sitting more of a straight position and not leaning forward. Lumbar pain from overstretched riding position. Again, handlebar height can fix that. And then poor pelvic and hip mobility can cause pelvic rocking. And you see that when the saddle is too high or when the handlebars are too low in that aerodynamic position. So essentially, we don't really think about these factors. I feel like when we were kids, we kind of just, sat on a bike, and if it was comfortable and our feet could touch the ground, that's it. But for people who are doing this as a sport, as an athlete, any one of these variables can put different stress on different parts of the body. So it's cool to break it down into these areas. And then the last one is neuropathy. Two main ones. There's perineal neuropathy. We can, it's all because of the saddle, whether the tilt is excessive, the saddle's too high, or the saddle's too narrow because your ischial tuberosities aren't being supported. And then, like Tyler said, ulnar nerve distribution of the Guyon's canal. But that's usually transient. So after all that is biomechanics. We'll take a pause. Any questions, comments, concerns, jokes? All right. They're like, all right, let's just move on, get this done. All right. So MSK rehab, that's the second part of this. This is much shorter than the first part. So MSK rehab, we're really talking about rehabilitation principles of, once we have an injury, what happens and how can we give our body the best chance of healing, and how can we prevent it from happening again. So that's really what we mean by musculoskeletal rehab. So when you have an injury, what things happen? So in the first is injury and inflammation, and those are within the first few days. You get bleeding, you get hemostasis, you get vasoconstriction, and the clotting initiates all your inflammatory pathways. That's why, there's even though the research is not definite out there, a lot of people say avoid NSAIDs. There's like this whole thing of moving away from anti-inflammatories because the first phase of healing is inflammation. So they say stopping that is preventing your body from doing its job. Phase 2 then is proliferation, fibroplasia, repair. That it takes weeks. And that is really when your cells are proliferating, your growth factors are there. And thing that they love to ask on boards is the type of collagen. So it's type 3 collagen deposition. So usually there's type 1, but in phase 2, when you have tissue injury, your body's actually going to first lay down type 3 collagen. And a lot of people may return to play during this time, especially if you're 6 or 8 weeks out. You feel good, you appear good, but that doesn't necessarily mean your function is good. You still might have that type 3 collagen that hasn't been replaced yet by type 1, which is what happens in phase 3. And that can take months to years. And, a lot of people we do send back 6 to 8 weeks later, but we have a gradual program that we have them increase to prevent the chance of injury. So really phase 3 can take months to years. And again, we don't have to wait years before putting them back, but really that's when your body goes back to that type 1 collagen, which is what it should be. And then your vascularity, cellularity is decreased. Injured tissue never returns to normal. And so that's why prior injury is a major risk factor for future injury. They talk about this baseball diamond approach to rehab. So the first part is pain control, next is motion, next is strength, then there's neuromuscular control, and then finally return to play. So we'll talk about each one of these, one slide each, to take a patient through rehab principles. And again, a lot of this we practice, but so pain control, symptom management. They talk about heat and cold. These terms, again, all science terms, I feel like is good to review and to know because they could ask us about it. Superficial heat is like, just think of a heating pad, right? Conduction, transfer between two bodies. Convection, transfer via fluid, like a hot water. And then there's conversion of electromagnetic radiation. Then there's deep heat, which, when we talk about ultrasound, like they use ultrasound to, in physical therapy. And then they use these other things that are much less common, but ultrasound really is the biggest thing to cause that heat, bring blood flow to an area. Then there's cold. Cold is through conduction and convection, which we saw in superficial heat, but then cold has something different, which is evaporation. As we know, it's like sweat cooling the skin when it vaporizes. Electrotherapy is the last one, and that's really TENS unit in iontophoresis, really muscle and nerve stimulation. And the best evidence to use electrotherapy is in like rehab after surgery. So for example, quadriceps, we want to wake those quads up. Justin, I don't know how much you're doing with these, but your quads shut down quite a bit. And if there's anything that you can do to try to wake them back up, this can certainly help. There's stretching. They love talking about the different types of stretching. Static stretch is the typical stretch that we all know. And as we know, we tell patients 30 seconds, time it out on your phone because you count less than 30 all the time. And then they talk about splint stretch. This isn't, I haven't seen this in other books, but they said it's low load, longer duration stretch, essentially, similar to static. But the best type of stretching, they say, is PNF, which is proprioceptive neuromuscular facilitation. Essentially, for us DOs, we can just call it muscle energy, where we're doing a isometric contraction, holding it, and then relaxing it, and then you take up the slack. And they say that this is possibly more efficient than other types of stretching. Ballistic stretching is the one that they say is not recommended because due to increased risk of injury. For example, if you're touching your toes, ballistic is kind of rocking back and forth to try to force yourself to touch your toes. And so that can cause spasms, lengthening of muscles, strains, and all that stuff. So increased risk of injury. So do not do ballistic. Strengthening. We have different types of strengthening. We have isometric. There is no joint motion in this type of strengthening, and they say for hypertrophy, this should not be the primary strengthening mode. There's isotonic, and that means there's a constant resistance. This is the one we're most used to. There's two types, concentric and eccentric, and we know eccentric is better. And then there's isokinetic. The benefits of this are unclear, so we don't use this much, but really the slower you move, you move slower and the resistance goes down. You move faster and the resistance increases. So it's a variable resistance, but a constant speed. So that was, we talked about pain control, we talked about stretching and strengthening. Now is neuromuscular control. So we say that, hey, they have full range of motion and full strength. Those are a lot of the things that we use to say, hey, this person might be ready to start going back into play. But we don't just send them out in a game, right? Because we know that their neuromuscular control can still be lacking. And so really, we want to make sure that we restore that and we test that before sending them out. Otherwise, they're going to have an increased risk of injuring themselves. When they talk about afferent, it's proprioceptive, and then efferent, which is muscular contraction. If we go back to like nerves and neurology, those terms. Strength does not guarantee good neuromuscular control. Again, even if you have normal strength, the proprioception might not be there. And how can you detect that? We assess balance in the clinic. We assess movement patterns. We can do video analysis, or we can just try sport-specific scenarios. That's why we say do a non-contact practice, do a contact practice. As long as you feel good, then go back to a game. So again, these are all rehab principles that I feel like we've been using all year, but really understanding why we do the things that we do, I think it helps when we really break down the science of it. Then we talk about loading. Loading really is in terms of tendons, and they talk about this cool thing called envelope of function. I don't know how they got this cool fancy term, but really it defines a tissue's capacity to do everything with load: generate load, accept load, transfer load, and dissipate load. Homeostasis means that the amount of load that you're giving a tendon is within its envelope of function, basically within its ability, the tissue's ability. If you have progressive overload, that means you're loading it beyond its envelope of function. And this is really what we do when we work out, or when we play sports, when we exercise. And then structural failure is if the load is greater than the tissue's ability to repair and recover. So progressive overload is where we want to be, because that's going to result in the tissue adaptation. You expand your envelope of function. And then rehab protocols for tendinopathy. Eccentric exercises, as we all know, for tendinopathy of the upper and lower limbs. In the lower limbs, the tendon is usually loaded above 100% of the body weight. It's actually kind of cool. They said that the general guidelines for Achilles is actually over 1,200 reps per week. And you can see the exercise routine that they gave there. But for patellar tendinopathy, it's significantly less. It's about half to even less than half. So I just thought that was pretty cool in terms of how often the patient rehabs for different types of tendinopathy. For stress injuries, we see this a lot. Knowing the high-risk stress injuries is super important to know. The femoral neck tension side. So as we know, the top side is the tension side, compression side is on the bottom. I just imagine if there was a crack here and you put weight from the top of the head, femoral head down, this side would compress, this side would get stretched out, so it would be more under tension. So that's high risk. Patella, anterior tibia, we have medial malleolus, base of the fifth, and great toe, and the sesamoid. So those are all higher risk ones that we should just keep an eye out for. As we do in PEDS clinic all the time, gradual reintroduction of that load. So we want to keep it within its envelope of function. And I'm done.
Thanks, Rohan. That was pretty good. I like it.
Sweet. I know that was a lot. It's a lot of dry stuff, but
I feel like I see a lot of those on the ITEs though, that as we review.
yeah, they love this stuff. I feel like just because it's just so factual. So there is a right or a wrong. And so I feel like a lot of the questions are worded as, a patient and their mom, pediatric patient and their mom comes in and they're wondering how they can, rehab X, Y, and Z, you know, and it's like, you know, sometimes they ask questions like that, but, you know, the answers we're giving is not, you know, the answer choices that we see on our exam. So it's very like technical answers that they're looking for. So. Cool, cool. Well, thank you guys.
Have a great day.
Good work, buddy.
Thanks, guys. Suze, you still there? Okay, maybe not. Well, take care, guys.
You too. We'll see you later.
All right, bye.